Okay, let's get started. Thank you for joining us today. My name is Eilish Hildebrand. I'm the Clinical Support Manager for Response Biomedical. Response Biomedical is sponsoring this webinar today. Just a little bit of history about Response. We are a Canadian company that was founded 30 years ago. We have been developing and selling the RAMP platform ever since. RAMP is a rapid, quantitative, self-calibrating platform for use in both the lab and at a point of care setting. The webinar today is on the clinical benefits of NT-proBNP and its growing importance as a cardiac marker. We're very lucky to have Dr. Kapoor presenting today. He's a leading cardiologist in Alberta. He unfortunately will not be able to present the webinar live because of scheduling conflicts with patients, and patients come first. But we were able to pre-record the session, and he will be joining us a little bit later on for a Q&A session. This webinar will last around 45 minutes, and that will include the Q&A session at the end. If you think of any questions during the webinar, feel free to pop them into the Q&A section, and we will answer them at the end. Nobody else will be able to see the questions, just us. So if we do not get to any of the questions during the session, we'll email you the results. And with that, I'm going to pass it over to Dr. Kapoor. Just need to pull it up.
Hi everyone, my name is Anmol Kapoor. I'm a cardiologist in Calgary. Today we'll talk about a very important topic, NT-proBNP, a simple test that could make our life easier and help our patients and also physicians around the globe. Before we talk about NT-proBNP, its clinical benefits, we first need to understand what is heart failure. Heart failure is a very complex syndrome, and by definition, it is characterized by typical symptoms of breathlessness, ankle swelling, fatigue, that may have signs of crackles in the legs, may have a patient symptom, difficulty sleeping at night, and sometimes they are sleeping with upright position. And sometimes it might have a structural problem with the heart, or sometimes it could have a functional problem with the heart, resulting in a reduced cardiac output that is causing people shortness of breath. And that's the summary of heart failure, but it's very complex. And it's very difficult for most of time patients to understand, or clinicians to understand how to diagnose it properly when patients present to their clinics or emergency rooms. What is an epidemiology of heart failure? It is a heterogeneous problem. It encompasses or covers a large patient population. So if there are 5 people in the room today sitting there, there's a lifetime chance that at least one person in those 5 people will have a heart failure guaranteed. And is that common prevalence of heart failure? And the cutoff values and how to diagnose it's very challenging has been. And what should be the cutoff values of various biomarkers, and how do we able to triage those patients and perhaps help them out? Because we know the mortality, the death rate of a severe heart failure, what we describe as someone with the left ventricular ejection fraction less than 30%, the lifetime expectancy is less than 50%, making 5 years. So sometimes the outcomes of a severe heart failure are worse than patients of certain cancers. So it's a quite serious problem, and it's very important for us to diagnose it in a timely manner. And NT-proBNP is that test that can definitely help us and our patients. And there are many different ways people have tried to diagnose heart failure before. We were looking for a near perfect solution in various patient populations. Chest X-ray is a very non-specific test. It can be very difficult and challenging to diagnose a heart failure. If someone has a COPD, which is a chronic bronchitis, those patient population often lungs look not really good shape. and difficult to diagnose a heart failure in that particular population. And the signs and symptoms become very difficult to diagnose on physical examination. Some patients may have crackles in their lungs and JVP, jugular venous pressure, sometimes difficult to diagnose it on a bedside, and not accurate sometimes if someone has a diastolic dysfunction and that part of heart failure. There are many other different ways we are trying to work in clinical setting, but definitely it was not the perfect, very limited sensitivity and specificity noted during various examination and study. From a prevalence perspective, it's estimated over 65 million people. I do believe there are roughly approximately 100 million people living with heart failure worldwide. As you can see, we don't have much data from Africa and the larger part of the world. The most data we have is from North America and Europe, and maybe some parts of India and China. But again, the data collection accuracy is not great in certain part of the world. Overall, the population is worldwide population estimated around at least 2% people living with heart failure. And just imagine those patients are having symptoms of shortness of breath and feel like drowning in water, which may be getting filled up in their lungs. What are the risk factors of developing heart failure? There are same risk factors which we have for heart disease. What are diabetes, high blood pressure, obesity, smoking? So those are the typical risk factors we see people developing heart disease such as a heart attack. And some of those patient populations lead to developing a systolic heart failure after having an MI or having a heart attack. And sometimes patients with diabetes or high blood pressure, they don't have a heart attack yet, but they have a LV dysfunction. The heart is not pumping as well, or the heart is not relaxing as well. So they are not able to get that cardiac output, and they feel out of breath. They're not able to walk as far as they used to. So the heart failure presents very differently in different subset of population. Some of the signs people can watch out for, typical symptoms, feeling tiredness, feeling fatigue, feeling burning sensation in the chest, feeling sweatiness, clammy, lower extremities, feeling cold, and unusually tired and exhaustion and the discomfort symptoms happening for heart failure population. Bloating is quite common. If they're feeling bloating in the stomach, it means the fluid is getting built up around there in the intestine area. The intestine is swollen up. If they're swelling in the lower extremities, going up to abdominal area. Sometimes people have to sleep whole night just in the chairs. They're not able to lie flat. So there are many difficult ways patients present. Cough is another symptom which presents with heart failure. And it's a dry cough. Sometimes it becomes a productive cough when there is too much fluid getting built up in their lungs. And they may feel dizzy when they're walking, or sometimes they're passing out. So it's a very common symptomatology can be seen in patients who don't have a heart failure. You can realize that. But the same symptoms can be seen in people with heart failure. So then how do you even differentiate who has a heart failure as symptoms overlap in our patient population? And one way to define in heart failure, once we diagnose it, how far a person can walk, are they symptomatic at rest? That's the first criteria we have to look at it. And we define that in New York Heart Association classification, NYHA, class 1, class 2, class 3, class 4. So it becomes easier among healthcare providers to communicate over the phone or document it, the status, the clinical status of the patient when we see that patient, with what class the patient was when we saw the patient and examine it. For example, class 1, there's no limitation. Person who has a diagnosis of heart failure, there is an ejection fraction, probably 30 or 40%, but patient does not have any symptoms, no limitation of physical activity, and they are able to move around. They have no symptoms at rest. Class 2 is when they have a limited limitations, so with a certain activities, but they're comfortable at rest. But ordinary activities make them tired. When they get to the next stage, where they have their marked limitation of their usual physical activities. They are feeling shortness of breath, even going to washroom. But they're comfortable at rest, but going to washroom is very difficult for the patient population. Class 4 will be defined when they're symptomatic even at rest. They can breathe, they can lie down, and they're feeling uncomfortable. So that's class 4. Usually patient population admitted to hospital at that time. So we see people in the community in class 1, class 2, class 3, class 4 usually in a hospital or in emergency rooms. So some of the key steps, how do you diagnose a heart failure? You start by a basic algorithm, basic pattern. Okay, what are the risk factors? Diabetes, high blood pressure, cholesterol, smoking history. But some people might not have those risk factors, might have a viral cardiomyopathy. Maybe they had a COVID-19, maybe they had a flu-like infection recently. So what you do is, besides examining, doing standard ECG, you would move to next level doing an NT-proBNP or a BNP biomarker. I like NT-proBNP much better, and we'll talk about later why is that. If the NT-proBNP levels are higher, that gives you a very high confidence that there is a heart failure we're dealing with it at that time. At that time, doing an echocardiogram is a good test to assess the LV function if they never had an echocardiogram done before. If there's abnormalities, you can define it if they have ejection fraction with a preserved pump power or reduced pump power, depending on how the cardiology team defines heart failure based on that. And that will help them decide the treatment modalities or various diagnostic evaluation they might have to do for the patient. Usually, this is how we work in North America. When we see a patient in the emergency room, in our office, or on the ward, when they have a sudden onset of shortness of breath, NT-proBNP is a test that very much helps us out every day. It is recommended test, look at the level of evidence, is class 1, and the level of evidence is better than ECG, better than echocardiogram, better than chest X-ray, or all the blood tests we do, including CBC, electrolytes, creatinine, lipids, and all the other stat tests we do. NT-proBNP still has a better level of evidence in class 1 indication of diagnosing suspected heart failure. As we talked about the workup, traditionally people who are having acute onset of heart failure, and they would present to emergency room or to various offices. The doctors would be doing traditional tests, chest X-ray, blood testing, traditionally done where there's no NT-proBNP ordered with the CBC, electrolytes, creatinine, glucose, but after that, they're still not comfortable at that time. So if they have not added an NT-proBNP, by adding NT-proBNP to those investigations and the care map and the plan the clinics can implement, it makes their life much easier. They can rapidly triage the patient and with a certain level that they are higher based on their age, and provide them clinical care much faster than waiting and do a trial of Lasix or trial of some other medication. Also, it's very, very important to be able to understand how this algorithm works and how we can help our patients. And what is BNP? And BNP can be divided into NT-proBNP versus a non-NT peptide. And usually it helps us diagnose the patient population wherever we are not certain, especially patient population who have COPD. They are shortness of breath. Is it the heart? Is it the lung? I don't know. You do chest X-rays. You don't know still. And you are stuck to the same question. How do you diagnose a heart failure? And you do an echocardiogram. At that time, echo comes back, for example, normal pump power. So a person could still have a heart failure with a preserved ejection fraction. So NT-proBNP is very helpful in differentiating that patient population. There are many other reasons NT-proBNP can be elevated in patients, such as someone have a heart failure, someone is having acute MI, myocarditis, or if they're having a pulmonary embolism, if they have an underlying valvular or congenital heart disease. Anything that puts pressure, increases pressure inside the myocardium, inside the left ventricle or the right ventricle, that's where the leakage of the NT-proBNP happens, which you pick it up in the blood. And sometimes people who don't have a heart disease, NT-proBNP could be elevated, such as older patient population. Their BNP could be a 900, which is normal for them, considering their age, but a 900 in a 30-year-old man is quite high. So that will be diagnostic for heart failure. So it's very important to understand the age cutoff values. But at the same time, someone has a stroke, someone has a brain hemorrhage, someone has a infection, someone has a liver dysfunction or cancer that is putting pressure on the heart, they may find NT-proBNP or BNP level to be elevated. And these are two different ways people can evaluate BNP. BNP is an active hormone. Levels are lower, shorter half-life, often variable. But there's a very common medication that is getting prescribed across the globe in heart failure population, Entresto. You cannot use BNP test to evaluate heart failure if someone is on Entresto. And often levels are not standardized across the various hospitals, various labs. So NT-proBNP is a much better option. If they are on Entresto, it still helps you decide if they're acute and chronic heart failure getting worse, versus if they have a stability for a long time and suddenly decompensated for some reason. It is standardized across all the platforms, so highly reliable test, much easier to use. RAM technology, which I have personally used, quite an achievable scientific accomplishment, able to provide NT-proBNP testing at point of care within a few minutes when person is having a difficulty to breathe. The biggest challenge, just think of this patient population. So they have a difficulty breathing, they have a fluid in their lungs, they're drowning inside, and just think of traditional system, a doctor orders a blood test, and they have to now drag themselves, go to the lab, and get the blood drawn, then the wait for the blood test to come back, then drag themselves to doctor's office to get the result, and then perhaps get some treatment that delays their prognosis and perhaps pushes them towards hospitalization or ICU or CCU hospitalization. So, but if we can use the RAM technology at point of care, we can cut all this wastage of time. Within a few minutes, we are able to get this blood test, which helps the patient in a timely manner. And RAMP NT-proBNP system, it achieves the satisfaction level with heart failure patients versus the conventional testing methods. Personally, I have used it, and I use it in my heart failure patient population. This is one of our centers in Calgary, Advanced Cardiology. We did a study over 22 months, over 100 patients, and they were enrolled. And as you can see, 96% patients said that knowing the results within a single patient visit, where they don't have to come back again, was very helpful, which helped reduce the anxiety to help understand if they have a heart failure, if they don't have a heart failure. And 99% of the patients said that knowing the results within a single patient visit increased their understanding of the result and their current condition. And all my clinical staff love the system. 100% they were satisfied because ease of use, and the physicians who were providing care to the patients, they found very reliable to their presentation and able to make decisions at the point of care, the point of testing, and help the patient population. There's another study done by the company where they were comparison of capillary versus venous NT-proBNP levels, which was quite a positive study to look at it from this scatter plot graph, which is comparing capillary NT-proBNP level versus venous, which is usually taken for various testing methods. And as you can tell, the straight line indicates not many dots falling away from the graph. Very good result. When you divide them into various levels of NT-proBNP, low, medium, and high, the patient population that was tested on, very similar results. If the age group was less than 50, venous versus capillary. If the age group was 50 to 75, very similar numbers in various ranges. If the patient population is older, very similar numbers. So in a summary, it was a very good study that provides a great amount of confidence for us to be able to proceed ahead with in the future capillary blood testing for the patient population. And the level of agreement very strongly in that favor. There's a good correlation between NT-proBNP levels in capillary and venous sample, which suggests that there may be a role for NT-proBNP point of care testing using capillary blood sample. These findings can be further confirmed with the larger studies, but this small sample study was very positive. So NT-proBNP test, this is how the cartridge in the machine looks like it. And I'll let team to help answer any questions you might have. Thank you so much for inviting me to speak and meet everyone. And I'm available to help answer any question you might have. Thank you.
Perfect, thank you. And I believe that Dr. Kapoor has now joined us. Welcome, Dr. Kapoor.
Thank you.
I would like to remind everyone that there is a Q&A function on the ribbon. So if you click on that, you can submit a question to be asked, and then we can go from there. We do have a first question coming in. Are you ready, Dr. Kapoor?
Yes, right on.
Perfect. Is there any time that you would prefer BNP over NT-proBNP?
Never. So BNP is just a shorter acting, and lots of heart failure patients are on medication called Entresto, and it impacts it and it makes it difficult to measure accurately. It has other interactions. So I'll rather use a test that has a fewer interaction and more accurate and longer lasting.
Hi. How are you?
How are you?
I'm breaking the rules and not writing my question in the chat because I also just wanted to say hi. I'm sorry, I'm a rule breaker. How are you today?
No problem. Thank you so much.
Good. Nice to see you again. I just wanted to ask a question. Around the world, we sell the NT-proBNP everywhere, and there's different protocols. I'm curious in Canada, are they using NT-proBNP? And I guess I'm thinking more about physician office practices than cardiologists to track the progression of heart failure patients, or is it still mainly used for diagnosis?
Well, we do look at the progression. Like I do monitor NT-proBNP for diagnosis, and if when this person is not feeling good and feeling a shortness of breath, and then I am introducing a treatment, for example, a water pill Lasix, or optimizing their other medications, and at that time I'll check it again NT-proBNP a few days later to see if it is going down. So the treatment I'm offering to the patient is taking it, I should expect some positive result. NT-proBNP should go down over time. And sometimes we find that they find a new baseline. It's like a creatinine. So at a base, not having a high BNP is a good thing, but sometimes people just make a new baseline, say 2000 number. And from 2000, they jump up to 5,000 and they come back to 2000 and they stay at 2000 for a while. So that helps me understand their baseline status, their creatinine. And then it allows me to monitor their progress as I'm adjusting their diuretics and other medications.
Perfect, thank you. Thanks, Angela. Is NT-proBNP concentration used for any other purpose other than comparing to the cutoff, like patient monitoring?
Well, it's only used for a higher NT-proBNP level. What it means, the heart is stressed. and why the heart is under stress needs to be investigated. Most common reason is heart failure. It is a preserved ejection fraction. If someone has a pumping power normal, but they have a left ventricular hypertrophy, they have sarcoidosis, or they might have other infiltrative disease, or they might have developed COVID-19 infection from the embolism. So the heart is stressed, and that is a marker the heart is stressed, which carries a poor prognosticator in those circumstances. It's like a troponin. When in people in ICU, the troponin goes higher. Doesn't mean they're having an MI, it's just the heart is stressed. NT-proBNP is a more accurate way than the troponin. Troponin is more of a marker for MI and ACS. It is weakly positive in ICU patients, but NT-proBNP goes very high in ICU patients with the heart is under stress. So that's what the marker is. You can use it for heart failure patients or non-heart failure patients or heart conditions, which can put a person heart at risk. And you can measure the response to the treatment and to see when it normalizes or at least gets to the new baseline, so you can monitor the progression.
Perfect, thank you. Can NT-proBNP identify each of the 4 classes of heart failure that you were describing?
Well, that's a class, the symptomatology. How do you diagnose a person? How you classify a person? How you describe a person? It's like describing, look, my mom, so she has a heart failure, and how do you describe over the phone, or how you categorize how she's doing? Well, she's okay at rest. That's number one, or not okay at rest. Second is, can she go to washroom without feeling shortness of breath? Can she go outside the main door of the house and walk around the house? Can she walk more than 1 block to the next grocery store and pick up milk or bread? So those are the ways we look at it. So if she's not able to walk to the grocery store and feeling shortness of breath, so that is class 2. If she can, that's class 1 NYHA. So if she's having difficulty, shortness of breath, just coming to the outside of the door of the house or going to washroom, so then class 3. And if she's feeling bad at rest, still with the shortness of breath, of course she can't go to grocery store, can't go to the main door, so she cannot go get out of the bed. That's class 4. So essentially NT-proBNP is helpful for all those 4 classes. It all correlates with the symptomatology. If the symptoms are there, NT-proBNP should be elevated.
Perfect, thank you. Have you seen NT-proBNP being used during the tracking of COVID, like the patient prognosis?
It is. It is very commonly used test in emergency rooms. It's commonly used test in admission in hospital, because we don't know if someone is shortness of breath, why they are. If someone post-COVID, long COVID is quite commonly, we see it now. After 3 months, 6 months, people are feeling shortness of breath. And we do check their heart pump with an echocardiogram, which can back say normal or not normal. But NT-proBNP is a very helpful test in that patient population too, because they're shortness of breath. We don't know why. Are they having a pulmonary embolism? Are they having a blood clot, like a D-dimer that is positive or weakly positive? So is there a stress on the heart? So NT-proBNP is a very good test to exclude any stress that a person might be suffering in their heart.
Perfect. What is the most common problem between, for interpretation of results with NT-proBNP?
The most common problem is age. Older people have a higher cutoffs and versus a younger person. As mentioned, if my NT-proBNP level is say 350, it is high. But if my dad, he's 75, and his level comes back is 400, it's normal. So age is the biggest cutoff. So we have to make sure what the patient age is before we describe them as under heart failure or not under heart failure.
Great. Why has heart failure become more prevalent in young people, and what can be done to prevent heart failure?
Well, obviously, we have to look at the modifiable risk factors. What are the modifiable risk factors? Diabetes, high blood pressure, high cholesterol, smoking, the factors we know. But young people also do more than these just things. They drink alcohol, and too much alcohol can cause cardiomyopathy, irritates the heart muscle. People develop cardiomyopathy, known as ischemic cardiomyopathy. What else do kids use or young people use? Cocaine, other drugs. So that can also increase the risk for cardiomyopathy. What young people can also get exposed to. They go to party, they go to some crowded places, they get exposed to various viruses, such as COVID-19 or some other viruses that can put them at risk for developing cardiomyopathy. So things you can modify, things you cannot modify. You can modify genetic reasoning. There is a now genomic test that can be done. We do that now in Canada, but some countries might not have that access to those genomic sequencing. So there's some genetic predisposition for that, but you can modify it. You can stratify that. But definitely look for the reasons why people would be developing heart failure. Again, every 1 in 5 person will have a lifetime risk of developing heart failure. It's guaranteed. So among your 5 friends, 1 will have a heart failure, guaranteed. So try to modify the modifiable risk factors, non-modifiable, difficult, but your cardiologist can help you.
Great. You mentioned that the baselines or thresholds for NT-proBNP levels are different across different countries. Do you see this changing towards a consensus over the next few years?
Well, the numbers of NT-proBNP are quite similar. I think we have made we already understand now, like in Alberta, in Canada, Calgary. So we have a cutoff. So we stick to that cutoff, and well, I'll be happy to share with your team, and they can follow the same cutoffs. It has been validated, accurate. Alberta Health Services follow those cutoffs to describe BNP being higher or being lower. ESC is also defining them. AHA is defining them. So we just, if you can start to follow those cutoffs, become easy then.
Great. And are there any gender-based differences in NT-proBNP concentration?
Not real. It's just a matter of heart is under stress and what is the reason heart is under stress. The woman might be having a Takotsubo cardiomyopathy or broken heart syndrome more often than men. There might be palpitations or tachycardia that could be triggering the high NT-proBNP levels. Again, what is the cause of a high NT-proBNP levels? But that should be explored not because of men or women.
Mm-hmm. Okay, great. I think we'll do 2 more questions. Have you used the ramp NT-proBNP for guiding medical therapies?
Yes, as mentioned, people, when I give them Lasix or just medications, want to see if they're getting better, the NT-proBNP should be coming down. It may be peaking maybe next day while checking it, or maybe in 2 days I'm checking it, but when the patient comes back, they're feeling better or they're feeling reasonable. Then I look at the NT-proBNP numbers. If it previously was say 5,500 and they come back, it is around 5,300, not much difference. Even the patient may be feeling okay, but that indicates the pressure in the heart is still high. So I would go up on my Lasix to see if I can bring it down towards close to baseline.
Perfect, thank you.
I think I'm interrupting again. Can I take the final question?
I think she should be penalized here.
Yep, I think everyone feels the same way as you do. I just have one about the future of heart failure and the patient population. I had the opportunity to meet a patient in Vancouver years ago, and the prognosis was very poor, and everything she did to try to, you know, reverse it, it was really not possible. She was able to manage it and live a few extra years. Do you see a future where heart failure is really not something we have to worry about anymore? Are there any treatments on the horizon that people can look forward to, or that you've seen that could give them at least a better quality of life and more longevity?
Well, we will not be able to cure heart failure because it's aging, population aging, we all get old. That's why lifetime risk is 20%, 1 in 5 person guaranteed to have a heart failure. Some patients, we can help them live longer with the medical therapy. The prognostication parameters, are, the more data we are gathering, is getting better. So yes, for that patient, she might be okay with the medical therapy for a long period, or she might not be. NT-proBNP does predict if someone's levels are persistently high. So some patient whose levels are, say, 3,000, 5,000, 8,000, persistently on the higher side, despite you offering them the maximum medical therapy possible, that's a bad sign. So they probably will not live long. So it is a poor prognosticator, and the way you can predict who might not be able to make it a year or 2 or longer.
Perfect. Thank you so much. I think that's all the questions that we're going to take. So if we were not able to answer them during this session, we'll email you a response. Thank you so much for being here, Dr. Kapoor, and for your presentation. Really appreciate it.
No problem. Thank you so much for having me.
Of course. Thank you. Goodbye.